Okay, so today we're going to dive into some pretty interesting material, right? We've got these super detailed medical notes and a bunch of follow-up questions, all centered around this middle-aged guy who's had a mechanical mitral valve replacement.
Sounds intriguing.
Yeah, and the cool thing about this deep dive is that we're going way beyond just a simple diagnosis. We really want to get into the nitty-gritty of what it's like to live with this condition long-term. What are the things you got to watch out for, the potential complications down the road, and how you manage all of that on a day-to-day basis.
I'm in. Let's break it down.
All right, so let's start with the initial picture we get from these notes. We've got this middle-aged man, and right off the bat, we know he's already rocking a mechanical mitral valve.
That's a pretty key piece of information right there.
Yeah, it sets the stage for everything else. And we also see he's got 2 central sternotomy scars, which tells us he's been through some surgically speaking. Now, his heart rhythm is sinus, meaning it's normal and regular, coming from the heart's own natural pacemaker.
Good to know.
Right. And his pulse pressure is normal, his jugular venous pressure, or JVP, looks good, and his apex beat is also normal. No sign of a right ventricular heave either.
So far, so good, it seems.
But then we get to the heart sounds, and this is where things get interesting. There's a metallic right first heart sound, and a soft systolic murmur that's loudest at the apex.
Okay, now we're talking. That metallic first heart sound is already giving us a lot of information. You see, the first heart sound, or S1, marks the very beginning of the heart's contraction.
Right, when the mitral and tricuspid valves close.
Exactly. And in someone with a mechanical mitral valve, like our guy here, the artificial valve closing makes that distinct metallic sound we're hearing. And because it's on the right, meaning it's loudest, where we typically hear the mitral valve, we know right away which valve is mechanical.
Makes total sense.
Now, the soft systolic murmur, that's something we'll definitely want to keep an ear out for and see how it evolves over time.
For sure. And it seems like his main complaint, the thing that really brought him in, was breathlessness.
Yeah, that's a common symptom in heart conditions, and it's definitely a red flag that needs investigation.
Absolutely. So the notes tell us they did a whole battery of tests. Inflammatory markers, full blood count, biochemistry, chest x-ray, ECG, and an echocardiogram.
The usual suspects, but all important to rule things out and get a complete picture.
Definitely. And they mentioned that if these initial tests don't give us a clear answer for the breathlessness, the next step would be to take a closer look at his respiratory system. But before we get sidetracked, let's go back to the question of why he needed that mitral valve replacement in the first place.
Oh, right, the million-dollar question.
The notes highlight a couple of things that weren't present, which is interesting. They say there's no evidence of pulmonary hypertension, and he's in sinus rhythm. So what can we infer from that?
Well, no pulmonary hypertension, meaning high blood pressure in the arteries of his lungs, and a normal heart rhythm, like sinus rhythm, they kind of point us away from one common culprit when it comes to mitral valve problems: mitral stenosis.
Mitral stenosis, so that's when the mitral valve is narrowed.
Exactly. And when that happens, over time, it can cause a buildup of pressure in the left atrium, making it enlarge. And that enlargement can often lead to an irregular heart rhythm called atrial fibrillation, not sinus rhythm, which we know he has. Plus, the increased pressure can eventually cause pulmonary hypertension.
Ah, I see. So the fact that those things aren't present makes mitral stenosis less likely.
Right. So we got to consider other possibilities.
Which leads us to the 2 main suspects listed in the notes: mitral regurgitation and infective endocarditis.
The classic showdown.
So mitral regurgitation, that's when the valve doesn't close properly and blood leaks backward, right?
Precisely. And infective endocarditis is an infection that can attack the heart valves, including the mitral valve.
Nasty.
It is. And as we'll learn later on, infective endocarditis was actually the reason for his original valve replacement.
Spoiler alert, but hold on, before we get there, let's talk about what it means to live with a mechanical mitral valve long term. What are the absolute must-knows when it comes to managing a patient like this?
Okay, so the long-term management really boils down to 2 key things. Number 1, we got to keep a close eye on how well that valve is working. And the main way we do that is with regular echocardiograms.
Like an ultrasound for the heart, right?
Yeah. It lets us see the valve in action, check for any leaks, blockages, or other problems, like a regular checkup for the valve itself.
Gotcha. And what's the second thing?
This one's non-negotiable, especially with a mechanical valve: lifelong anticoagulation.
That's blood thinners, right?
Yep. And it's super important because mechanical valves are made from artificial materials. Your body sees them as foreign objects and tries to form clots on their
It
surfaces.
doesn't sound good.
It's not. These clots can break off and travel to the brain, causing a stroke, or they can mess with the valve's ability to open and close properly, leading to valve malfunction. So, lifelong blood thinners, like warfarin, are essential to prevent this.
Wow, so it's a pretty big deal.
Oh, absolutely.
Hmm.
And we carefully monitor the intensity of the blood thinning using a test called the INR, or International Normalized Ratio.
INR, so what does that tell us?
It basically measures how long it takes for your blood to clot. And we want to keep it within a specific range called the therapeutic window. Not too thin, not too thick, just right to prevent clots without causing excessive bleeding.
Makes sense. Now, moving on in this particular case, we see that the patient is scheduled for a cystoscopy with a biopsy.
Okay.
And that immediately brings up the issue of preventing endocarditis.
Sure.
So what advice would you give him about this upcoming procedure?
Well, this is where things get a little tricky. You see, any medical or dental procedure that could potentially let bacteria into the bloodstream, it carries a risk of infective endocarditis. And that risk is even higher for someone with a prosthetic heart valve.
Oh, I see. So even a small amount of bacteria getting into the bloodstream could be dangerous.
Exactly. We call that bacteremia, and those bacteria could potentially land on the artificial valve and cause a serious infection. So for procedures with a known risk of bacteremia, like the cystoscopy with biopsy, we usually recommend prophylactic antibiotics.
Prophylactic antibiotics, so you give those before the procedure.
Right, as a preventative measure,
Smart.
hopefully. And it's not just cystoscopy. The notes mention a bunch of other examples like major dental work, abdominal surgery, even a sigmoidoscopy with biopsy.
So basically, any invasive procedure needs careful consideration.
Absolutely. The key is to identify procedures where there's a significant chance of bacteria getting into the bloodstream and where that could lead to an infection on the prosthetic valve.
And I bet patients with prosthetic valves are probably freaking out about every little medical or dental thing, right?
Yeah, it can be a lot to think about. That's why we often give them cards they can show to their healthcare providers. These cards explain their condition and the recommendations for antibiotic prophylaxis in different situations.
What's really helpful.
It's all about consistency and making sure everyone's on the same page.
Definitely. And it's good to reassure folks that routine dental work, like a regular checkup and cleaning, doesn't usually require those prophylactic antibiotics.
Right.
That's a common misconception. Okay, now let's fast forward about 5 years. Our patient comes back for a follow-up appointment and a new systolic murmur is detected.
That's definitely something we want to investigate further.
Yeah, it kind of sets off alarm bells, right?
Yeah,
Especially in someone with a replaced mitral valve.
for sure. The biggest concern is that the replaced mitral valve might be leaking. We call that incompetence.
And why would that happen after all this time?
Well, there are a few possibilities. It could be wear and tear on the valve components. They're not indestructible. Or it could even be a delayed presentation of a low-grade infection around the valve.
Bex.
Yeah, so an echocardiogram is definitely needed to get a good look at the mitral valve and see what's going on.
Makes sense. And the notes mention that we also need to check for other potential valve problems that could be causing the murmur, like aortic stenosis or tricuspid regurgitation. So how would you go about telling those apart just from examining the patient?
Well, that's where a good old-fashioned physical exam comes in handy. For tricuspid regurgitation, which is a leaky tricuspid valve, one of the key signs is visible V waves in the jugular venous pressure. You can actually see these pulsations in the neck veins.
Wow, so it's like a visual clue.
It is. When it comes to the murmurs themselves, aortic stenosis, which is a narrowing of the aortic valve, usually causes what we call an ejection systolic murmur.
An ejection systolic murmur, what's that like?
It has a kind of crescendo-decrescendo shape. It builds up to a peak intensity and then fades away during the heart's contraction. And you typically hear this best in the aortic area, which is usually the second intercostal space on the right side of the sternum.
Okay.
Now, tricuspid regurgitation, on the other hand, usually presents as a pansystolic murmur.
Pansystolic, so that means.
It lasts throughout the entire heart contraction, and you typically hear it loudest at the lower left sternal border where the tricuspid valve sounds are most prominent.
So the location where the murmur is loudest is a big clue.
It's a huge clue, and the characteristics of the murmur itself can also help us differentiate.
Awesome. Now let's move on to some other findings from this 5-year follow-up. It's good to see he's still in sinus rhythm.
Always a good sign.
Right. And the 2 sternotomy scars are still there, obviously. But then they mentioned multiple Campbell-De Morgan spots and a mark on his posterior thorax that was initially thought to be bruising, but turned out to be a telangiectatic nevus. What are those?
Okay, so Campbell-De Morgan spots are also called cherry angiomas. They're these common, benign skin growths that tend to pop up in middle age. They're small, raised, and usually bright red.
Oh, like those little red dots some people get.
Yeah, those are the ones. Now, telangiectatic neva are sometimes called spider neva. They're also pretty common and involve blood vessels. They have a central red dot with tiny blood vessels radiating outwards, kind of like a spider's legs.
Interesting. So in this patient's case, with his heart history, are these skin findings something to worry about?
Honestly, they're most likely just incidental.
Yeah.
Probably not directly related to his mechanical valve or his heart condition, but it's always good to note all findings during a thorough exam, even if they seem benign, just to make sure we're not missing anything.
That makes sense. And the fact that they initially thought the mark was bruising just goes to show how important careful observation is.
You got it.
Now, those two sternotomy scars, those are definitely significant, right?
Oh, yeah. Two sternotomy scars pretty much scream multiple open heart surgeries.
Wow.
And since there's no mention of leg scars, it's less likely that the second surgery was a coronary artery bypass graft, because those often involve taking veins from the legs.
Ah, interesting.
So the most likely scenario is that he had another surgery related to his mitral valve, or maybe some other heart issue that popped up after the initial valve replacement.
So even after a valve replacement, it's not always smooth sailing.
It highlights the fact that managing patients with prosthetic heart valves can involve dealing with new complications down the line. It's a journey.
Absolutely. Now let's circle back to the initial presentation for a sec. Remember that metallic heart sound?
How could I forget?
Right. They specifically mentioned that it was a metallic first heart sound coinciding with the pulse, which indicates a mitral valve replacement.
Hmm.
And they made a point of differentiating that from a metallic second heart sound. Why is that distinction so important?
It all comes down to the timing of the heart sounds within the cardiac cycle. The first heart sound, S1, like we talked about, marks the beginning of systole when the mitral and tricuspid valves close. So a metallic first heart sound tells us there's a mechanical valve in either the mitral or tricuspid position.
Right.
Now, the second heart sound, S2, that happens at the end of systole when the aortic and pulmonic valves close. So a metallic second heart sound would point to a mechanical valve in either the aortic or pulmonic position.
Ah, so the timing tells you exactly which valve is mechanical.
Exactly.
That's brilliant. And finally, the notes confirm that his original mitral valve replacement was due to infective endocarditis, just like we suspected.
Full circle.
It really emphasizes how important those preventative measures are, like the prophylactic antibiotics we discussed.
You said it. Endocarditis is a serious business, whether it's on a natural valve or a prosthetic one.
Absolutely. And it's encouraging that his mechanical valve has been working well for those 5 years, no signs of leaking, and he's still in sinus rhythm.
Those are all good signs, definitely point to satisfactory valve function, but ongoing monitoring is still key, just to catch any potential issues early on.
Got it. And there's one last point I wanted to touch on from the notes. It mentions the whole valve repair versus replacement dilemma.
Ah, yeah, classic debate in cardiology.
They specifically say that in a younger patient with isolated mitral valve prolapse, mitral valve repair should be the go-to option whenever possible. So why is repair preferred over replacement in that scenario?
Well, when we can repair the valve instead of replacing it, we're preserving the patient's own natural valve tissue. And that's a huge advantage, especially in younger folks.
I can imagine.
Because with mechanical valves, you're looking at lifelong anticoagulation, which comes with its own set of risks and challenges. Plus, a repaired valve often leads to better long-term outcomes in terms of valve function and a lower risk of complications like blood clots and infections.
So replacement is really a last resort when the valve is beyond repair.
Pretty much. Or when a repair is unlikely to hold up over time.
Okay, that clarifies things. So, to sum up this awesome deep dive, we've really gone through the ins and outs of managing a patient with a mechanical mitral valve. We started with his initial presentation and figured out that his first valve replacement was due to infective endocarditis. Then we talked about the essentials of his long-term care, like those regular echocardiograms, and the absolute need for blood thinners.
It's a lot to keep track of.
It is. And then we had that crucial discussion about preventing endocarditis, especially before any invasive procedures, with those prophylactic antibiotics. And when that new systolic murmur appeared after 5 years, it reminded us that monitoring is an ongoing process, and we got to be ready to differentiate potential new valve problems.
Right. It's a dynamic process for sure.
We even deked out on the importance of seemingly minor details, like the timing of that metallic heart sound and what those surgical scars tell us. It's amazing how much information we can glean from these little clues.
It's like putting together a puzzle, right? All these pieces fit together to tell a story.
So true. And on that note, here's a final thought for our listeners out there. Think about the intricate dance between those clinical observations we make, the fancy diagnostic tools we use, and the proactive steps we take to prevent problems. They all work together to keep people with mechanical heart valves healthy and thriving. And it's not just about the big stuff. It's about paying attention to the seemingly small things, too. Because sometimes those tiny details, like the exact timing of a heart sound or a weird skin marking, can be the missing pieces to a complex medical puzzle. It makes you wonder what other seemingly silent clues are out there, hiding in plain sight, just waiting to be discovered. It's a pretty amazing world, and we hope this deep dive has given you a glimpse into the complexities of managing a patient with a mechanical mitral valve. Thanks for joining us on this journey.